Today, we'll continue our conversation about home care by focusing on palliative support on the Sunshine Coast, as well as hospice and advanced care planning. My name is Joanna Puros, coming to you from sunny Gibsons today. I am very proud to sit on the board of the Sechelt Hospital Foundation and also to be your host, as it were, for this very important discussion today. I'd like to acknowledge that we live and work on the unceded homelands of the Sechelt Nation and all First Nations people that have called this land home. Support for today's program comes from our very good friends at the Sunshine Coast Credit Union. So last week we introduced you to some of the people that are involved in home care on the Sunshine Coast. Everybody from those who schedule the visits, those who take your initial call, to the nurses and the home care workers that come to your home, the social workers, the physical and occupational therapists. It was an action-packed show. Today we want to look at the end of life part of home care and support. As we always do in Medtalks, we welcome your questions and comments. Please use the chat feature in YouTube, and we will collect those and try to get to them at about 4:45. It's my pleasure to welcome once again last week's co-host, Shari Myhill-Jones. Shari is the Manager of Home Care Services here on the Sunshine Coast. I'd also like to introduce you to Patrina Wing, who is a registered nurse, Vancouver Coastal Health Palliative Care, and Dr. Carmen Guja, who is a local GP and also specializes in palliative care. So, Shari, last week we met some of the team, but we decided that the palliative care piece was so big that it needed its own show. Talk to me about that.
We talked a lot about our services at home care, and as you said, we just briefly touched palliative, and we realized it was such an area of expertise that we needed to have another Medtalks and bring Patrina and Carmen into the conversation to fully understand the services that we offer on the Sunshine Coast. So I'm happy to have Patrina and Carmen here today with me.
So Carmen, maybe we'll toss it over to you to get us started on what is palliative care, big terms, and what does the journey look like?
Shari, I'm really happy to be here today to talk about palliative care and help everybody get a better understanding of what that really means. So I wouldn't be surprised if a lot of you who are listening here today actually feel frightened when they hear the term palliative care. And maybe even think, palliative care, that means no more care. That means no more medical care. We're just focusing on comfort. That's it. And I think that's a really common misconception. And as palliative care grows and changes, as our medical world grows and changes, it's important to kind of understand what it really means. So I wanted to share with all of you what the WHO actually defines palliative care as. So they define palliative care as an approach that improves the quality of life of patients and their families facing the problems seen with life-threatening illness through the prevention and relief of suffering from pain and other problems, whether they be physical, psychosocial, or spiritual. And I think you might all be surprised that nowhere in that definition do we hear the word death or dying. I found that pretty surprising when I first started this work. So some kind of highlights of that definition and what does that mean when we kind of look more deeply into it. It means providing relief from pain and other distressing symptoms, again, whether they be physical, like pain, shortness of breath, or nausea, whether they be emotional, depression, anxiety, or spiritual. Palliative care intends neither to hasten or postpone death, and it's about living well with a serious illness throughout that journey from the time of your diagnosis until the time you die. It's about using a team approach to address the needs of patients and their families, including bereavement counseling if needed. So really thinking about it's not just about the patient, it's not just about the doctor or the nurse, it's about all of those people. It's about the family, it's about all the people that you guys met at the last Medtalks. We're all part of a team because it becomes complex and no one person can do one thing for a patient. And the patient themselves is really important in guiding their care and telling us what's important to them, what they want out of their care, and especially keep us up to date on what they want from their care as their journey goes on, because what their healthcare wishes are often changes as their health changes. And I think something that's really, really important to remember about palliative care is that it can be given with other treatments for serious illnesses. So it's not an either or, hey, you can only have chemo or palliative care. It's you can have them together. And so that's why, now when we think about palliative care, we think about bringing it in to a patient's journey pretty much right when they're diagnosed with a serious illness. Do we mind changing the slide just so we can see the palliative journey? And so I think that this slide, which is actually on the new palliative care brochure for the Sunshine Coast, I think this really highlights that palliative care is a journey. And so starts right when you're diagnosed with a serious illness. Part of palliative care is having a goals of care discussion, making an advanced care plan. So really making a plan A of what you want to do with your healthcare around your diagnosis, your plan B if things don't go to your plan of plan A, or if you've changed your mind later on in your journey. And so you'll see that focusing on curing a disease like a cancer, even controlling a disease with treatments, happens in conjunction with palliative care. So happens in conjunction with treating your symptoms, physical, spiritual, psychological. As your journey progresses with your illness, the disease, it just might not go where you get cured, or you might not have that control of disease that we had hoped from treatments. And that's where palliative care might become more and more important and kind of tip that balance where you were getting both. And maybe now you're starting to get more palliative care, and we're not focusing so much on cure and treatments, but focusing more on quality of life. And really, when your illness has progressed to a point where treatments aren't working anymore, and it really is time to focus on quality and comfort. And that's something that's important to you, is when you and your family physician will actually make a decision together that, hey, we need more help here. We need to make sure you have the other support you need now that your illness is changing and the trajectory and goal is changing a bit. And so closer to kind of your best guess, maybe last 6 months, last year, like we would refer to the palliative care nursing team at Sunshine Coast Community Services, a lot of the folks that you met at your last Medtalks. And I was hoping that Patrina could talk a little bit about what happens at that point once you are referred to our palliative care team. Again, and that's just so that we have more people to support you when your goals have changed to focus more on quality of life.
Yes, so when a referral comes through to home care services, it would come through to myself and my colleague, Joanne. There's two of us. We're palliative care resource nurses, and we support our home care team in providing palliative care services. And so if you watched last week, you would have met many of our home care team. So it could be home support workers, home care nurses, all of whom have training in palliative care and are very skilled at delivering palliative care. Social work, occupational therapists, physiotherapists. So if there are things that are needed in the home, then our team steps in. But some of our visits would be just supporting, talking, listening with you, with your family, and we build a relationship, and we're there to offer support through your journey. And we build on that. So often those relationships are really deep and meaningful. And, our visits could be initially just every couple of weeks, just checking in, could be by phone. But as things progress, as Carmen mentioned, then our visits increase and our interaction with you and with family and loved ones increases. So yeah, as the journey goes on, it becomes this nice wraparound support.
Can I ask, are all physicians and all nurses as comfortable in the palliative care spectrum as the two of you are, or is it sort of a specific skill set?
Family docs are well versed in palliative care. It's part of the core training of becoming a family doctor. I did extra training at UBC, and so I'm kind of an extra set of skills if a family doc needs extra support, and just, an extra, when you have someone else who's outside of the of the situation, and they can kind of come in with fresh eyes. So I have that bit of extra training, but every family doc does have a basic foundation in that.
And as far as nurses go, it's kind of the same thing. Most nurses would have some knowledge and background in palliative care, but it is a specialty, and I've done extra training and certification with the Canadian Nurses Association, as has my colleague Joanne. So we're available to our nursing team. They can contact us. We have very good relationships with all the physicians on the Sunshine Coast. So I have worked in bigger centers, and I truly feel and believe that we offer a pretty highly skilled, very responsive palliative service here.
Can I throw a question out to the three of you, including Shari? I know that in many cases, people say that within the healthcare system, you have to be your own best advocate. When it comes to palliative, does that fall on the family, or do you just know who needs to step in when? Maybe could you paint me a little bit of a picture of this from the patient's perspective and the patient's family perspective?
I think, again, really good question. I think sometimes it can be hard as a patient or even as a family member sometimes to be able to know when it's time, I guess, to maybe think about a referral. So I think that's why it's really important to, whenever you have a serious illness, to have discussions with your family doctor, with your loved ones, people that you trust, and really think about, what do I want? What do I want out of my healthcare? What are my priorities? What am I willing to go through and trade off and willing to gain more time versus what am I not willing to do? What's my threshold to stop a treatment and maybe just focus on palliative care instead of having them both together? So I think it can be hard, but I think trying to include the people that you love and being open and having open discussions throughout your healthcare journey is really important. And I think it's important to know that it's not just the family physician who can refer you to palliative care. It can be a loved one. It can be you yourself as a patient. So I think some people do know themselves really well and know what they want and can make that call or can tell a loved one or their family doc. But sometimes it's the other people on your team who are supporting you and watching you go through what you're going through that might be the people who identify, hey, there's a change there. Hey, I don't think you're getting the same benefit that you were from your treatment or from these tests. And I think, it's more hurting you, and I'm worried about that. So sometimes, yeah, it does have to come from a loved one. And sometimes even our relationships can be complex with loved one too, and you have to hear it from a professional. So it might have to come from the nurse or the doctor. So I think it's just all about being open and having discussions.
So Shari, I'll ask you, when we were introduced to so many members of the team, some of them spoke really passionately about how they felt that it was a real privilege to work in the palliative side, but not all of them. Is there, again, same question that I asked Carmen and Petrina, is there a difference? Do people approach this aspect of care differently?
It is a good question to ponder, and I think about palliative care and home care, and it's not a line that you're either here or you're there. We care for clients throughout their senior experience, through chronic illness. And we work together as a team so those same people who you met last week, those care aides would be supporting that client before they entered a palliative phase. So the team would be the same. The faces would be the same. And I like to think that it's more or less seamless as our patients move through the system and into Petrina and Joanne's care.
Yeah, I would echo that, Shari, and just say yes. I mean, palliative care does encompass care of the frail elderly, so those clients may have been closely followed by a case manager over sometimes many years, and the case manager maybe doesn't have specific palliative expertise, but they know the client well, and so they may then partner with Joanne and I, and then maybe quite possibly bringing in home care nursing towards the end of life. And it is very much a team approach, and we are a fairly small team, so we communicate very well. We can communicate face to face, which is wonderful. And so Joanne and I, as palliative resource nurses, are a resource to the whole team in home care.
I know one of the things that you hear from people is, I don't want to have to go into hospital at this stage. So is there a time, I guess they're afraid that that's what will happen, and it isn't what they want. We heard overwhelmingly last week from all of the members of the team that people do better at home. They prefer to be at home. Is there a line where you say, you know what, we can't do this at home anymore?
Yes. There are situations where it isn't feasible. We do everything we can if that is someone's wish. And if things are heading in a certain direction and we realize either through caregiver burnout or not enough available support, then we would have another conversation. But we try very hard to respect a person's wishes, and it really is a conversation that keeps happening. It's not just one conversation, and in fact, people may have a certain plan, but they may change their mind and realize that their care needs to take place somewhere else, and often people come to that themselves.
I think kind of just to add to what Petrina was saying is that palliative care can be given in a variety of settings. So we've talked about giving it at home and how people tend to do better at home. It can be provided in the hospital if your care needs at home exceed what can be given at home, like what Petrina was saying. So when you're at home, your loved ones are providing a lot of the care in conjunction with the home care nurses who might be coming in and helping with meds and helping with any other care that you need. Your physician kind of helping the nurses to figure out what meds to give and when. So again, that whole team-based approach, but it is a lot for family. And sometimes just what you need at home just can't be given anymore. You kind of, for some people, you reach a limit, and that's what it would be. But just to reassure you, if that happens, that's okay, because we can provide palliative care in the hospital. We can treat a hospital room like a hospice room if we need to, where you're not going to have nurses coming in and checking your blood pressure every 2 hours and all that stuff. We try to make it very home-like and similar to hospice. And then hospice, again, on its own, we have 2 rooms here on the Sunshine Coast in Shorncliffe. And that's another place where you would have access to 24/7 nursing if you needed that at some point in your palliative journey, and it can be provided at home. And it can be given in long-term care too. So if someone is living in long-term care, they can get palliative.
So can we talk a little bit about the current workload? How many palliative people are we looking after at any given time? I'm sure it varies, but let's say today, what's the workload?
It really does vary. I would say it's kind of between 40 and 60 clients at any given time, and that includes sort of across the spectrum. Some of those people may be fairly early referrals, and we're not seeing them or contacting them very frequently, and it does include a bereavement follow-up.
And a lot of people ask, and certainly that was one of the things we touched on last week, I can't afford palliative. I can't afford to pay for anything. Are there costs associated with this type of care? And if so, what are they?
Not, well, there are some. So the government funds a benefit program called BC Palliative Care Benefit Program. And that will cover some medications. It covers medications that are related to symptom management. And it covers the cost of home support services. So that's care aids for personal care and that kind of thing, to a sort of a limit of, well, it's supposed to be 120 hours a month, I think, but we kind of, it's fluid. And it covers some equipment. So if someone needed an electric bed like they have in the hospital, but the benefit is really only meant for the last 6 months of life. Now, again, it's not a hard and fast rule, but yeah, it's supposed to be for the last 6 months of life. Home care nursing is covered under medical benefits. Am I missing anything?
No, I think speaking of the equipment.
Loan
covered. Loan covered that we visited last week. It is important, I think, for everyone to understand if being at home as long as possible, how important equipment is to supporting our staff in providing that care. So a hospital bed would make it safe. A hospital bed that's electric, goes up and down. It could be a commode. Just how important the equipment is for our team to be able to support you in your journey at home.
So I suppose the people that are really a little bit stuck would be those who are alone, who don't have family here because obviously you're not going to be providing round the clock care. That's just not in the system. Yeah. So what advice do you have for people who don't have immediate family or caregivers here?
Well, we support people for as long as we can at home. I'm just trying to think if we've ever supported someone right to the end of life who doesn't actually have someone else with them. I think probably for the very end of life, we would try to move them into a place where they could get round-the-clock care. But certainly, we put in as much support as we possibly can in order to honor someone's wishes to be at home. And if we increase our nursing visits as much as possible, but probably for end of life care, it's not really possible if there's no other person to come and help.
Yeah, and I've definitely had cases like that before, Joanna, and again, just echoing what Katrina said, the home care nurses become are even more vital. They're vital anyways, but they become absolutely vital in a situation like that. To try to respect someone's wishes to stay home on their own for as long as possible.
Can I ask you all a bit of a philosophical question? And it did come up a little bit last week. And that is, do we as a society, as a North American society, do we spend enough time learning how to talk about these things?
No.
No.
And the answer is? What do we do about that?
Yeah. Well, we're starting to have more and more of these conversations, and these Medtalks, and Carmen's done a lot of work. The Hospice Society have done a lot of work. We really do need to talk about it, and I say that and recognize that that's easier said than done. But there are these kind of death cafes and things throughout North America and elsewhere. A couple of generations ago, people died at home. People routinely died at home. They were not transferred to acute care, and extended families cared for loved ones. And obviously now families can be a lot more distant. On the Sunshine Coast, there's a lot of people who've retired here, and their families are not close by, and so it's more challenging. But the more conversations we have about death and dying, and what our wishes are, and what is important to us, the more we can, all of us, talk about it, the better, and make sure that our loved ones know our wishes, our friends, our family. So important. Can't stress it enough.
Well, and luckily we will be talking about that in just a few minutes. But Carmen, I know you have sort of a summary graphic to walk us through what is palliative care. So maybe if you could wrap that up for us with that graphic, that would be lovely.
Sure. So in summary, palliative care is a team approach to care. It focuses on living well with a serious illness. It means exploring what matters to you in the setting of a serious illness, meaning what are your priorities. It means exploring what suffering means to you and what is acceptable to you to relieve that suffering. It's ensuring your voice is always heard, and it can be provided in a variety of settings, at home, in the hospital, in long-term care, and in hospice.
And is this a conversation that GPs are initiating with their patients?
Not all. I hope more will. And it's okay for patients to initiate this conversation with their family docs too.
Great. Okay. Well, speaking of advanced care planning and thinking about all of those questions that Carmen has just outlined, I'd like to bring in Jackie Scott, who has been patiently listening to all of this stuff. And Jackie is a volunteer with the Sunshine Coast Hospice Society, and we have a video to introduce you to Hospice House. But first, Jackie's going to talk to us about a really, I think, wonderful initiative called the Greensleeve Program. So, Jackie, it's all you, my friend.
Thank you. Thank you so much. It is a real privilege to be here today to speak on behalf of the Sunshine Coast Hospice about the Advanced Care Planning Greensleeve Initiative. If we could just have the first slide, thank you. The Greensleeve Advanced Care Planning Initiative is a collaborative project that we worked on with local Sunshine Coast physicians, paramedics, staff at Sechelt Nation, and volunteers and staff at hospice. And we launched this pilot project last year after about a year of deliberation at the beginning of COVID. We launched it through the hospital, medical clinics, and palliative care team. So some of you may already have green sleeves given to you by your doctors or home care team. And now we're in the process of launching the Greensleeve Initiative to the community at large, because we believe that every adult should put some thought into an advanced care plan. And as you heard earlier from the rest of this panel, those conversations, that process of thinking about what's important is really key. Advanced care planning generally is a process that helps you have a say in the health care you'd like to receive if you get very sick and can't speak for yourself. And it's a process of thinking about your values and beliefs and wishes for future health care and personal care, thinking about who you'd want to make healthcare decisions for you if you can't make them for yourself, and then sharing those wishes and those decisions with the people you love and your healthcare providers. So you may ask, why should we have an advanced care plan? And the fact is that death is inevitable. None of us get out of this life alive, as the saying goes. And only 3% of us will have a sudden, unexpected death. The rest of us are likely to spend time living with chronic illness and medical treatments in the last months or years of our lives. And 60% of us will likely die in hospital. But advanced care planning isn't just about healthcare when you're dying. You could be temporarily incapacitated by an illness, for example, COVID or a stroke, or by an accident. And you may fully recover, but while you're unable to speak for yourself, who's making decisions for you? What kind of things are they being asked to think about? And do they know what your wishes are? So the green sleeve looks like this. It's a plastic vinyl envelope. It has magnets on the back. It's the container for your emergency medical information. And you would keep this with your medical documents on or near your fridge, so that if first responders are called to your house, they know to look for it. The RCMP, fire, paramedics, they're all part of this program, and they know to look for the green sleeve. The green sleeve contains emergency medical information. You would complete a form where you might outline your chronic or significant health conditions, any allergies you may have, implants, what your current medications are, and who your emergency contacts are. And this is really important for the paramedics, who are most likely the first people to treat you in the case of an emergency. If you can't speak for yourself, this information gives them the information they need to make sure you have the treatment that you need and want. It may also contain information about who will make decisions for you. And you may have documented this in a representation agreement, which is a legal document designating a decision maker, or you may have completed a list of family members. And that list is what doctors use to decide who would make decisions for you. And if you do have a chronic or a life-limiting illness, Carmen referred to the kind of conversations you would have with your healthcare providers about the degree of interventions and treatments that you may want. And out of that conversation, they may have given you a medical orders form known as a MOST, a medical orders for scope of treatment, or a no CPR form. And that would also go into the green sleeve and is a very important document for emergency care. So I'm hoping by now that you're all wondering where you can get your green sleeve. And if you are, if you could do the next slide, you can pick up green sleeves at your doctor's offices. All of the medical clinics on the coast have green sleeves. And you can also call hospice and arrange to pick up green sleeve kit from our Davis Bay office on Simpkins Road. So in addition to, the hospice's role is to manage this program or coordinate it. But in addition to that, we always do a lot of public education around advanced care planning. And we have a series of workshops in the month of April. We have 2 workshops in Sechelt at the Seniors Activity Center and 1 in Gibson's Library. So if you would like more information about those, you can go to our website, which is coasthospice.com/ACP, and that's all about the green sleeve. And there's a lot of resources there, links to more information about advanced care planning. Or you can email us or phone us, and those numbers will be shared on the website later as well. But one of the things that we've realized as advanced care planning educators is that while people are generally very motivated to do an advanced care plan, it can be a really challenging process to put an ACP in place. So we have a team of volunteers at hospice who are advanced care planning volunteer specialists. So if you can't get to a workshop, or you feel like you need extra support, you need somebody to really sit down with you and go over what an advanced care plan is, how to complete the green sleeve, then you can call hospice and we can arrange to have a volunteer sit down with you and work through that material. And that might be more than one meeting. It might be a series of meetings as you kind of work your way through the information that needs to be gathered. So I think that's all the time we have to talk about green sleeves. Our upcoming workshops are 2 hours each, so there's a lot of information there if you can come to one of those.
Actually, Jackie, I would like to ask you a couple of questions. I know that there are a lot of people living on the Sunshine Coast whose parents live elsewhere in the country as opposed to the other way around. Is this a province-wide initiative, a national initiative? How broadly is it available?
Advanced care planning generally is a national initiative, but a green sleeve program like ours is quite special. If you live in the Fraser Health area, then Fraser Health has had quite a long-standing green sleeve initiative. And there are a few localized advanced care planning initiatives like this in other communities, but no, this is quite unique. Alberta Health also has a green sleeve program through all of Alberta that's part of their healthcare system. But this was something that is really a locally motivated initiative. It came out of a conversation, sounds like the beginning of a joke, but it came out of a conversation between a doctor, 2 hospice volunteers, and a paramedic.
It does sound like the beginning of a joke, absolutely. And now, not to be a fear mongerer, but and anybody feel free to jump in on this one. I have heard from first responders over and over again that they will show up. Somebody is in some kind of medical distress, and no one knows anything. There's nothing on the fridge. There's nothing above the fridge on the shelf. Family may be there, and they're guessing. So what's the worst case scenario if there is nothing for them to refer to or for physicians to refer to?
Well, first responders have a very specific protocol in the case of a medical emergency. They have to provide a full scope of treatment to resuscitate someone. And you were asking earlier, Joanna, if we talk enough about this, and absolutely we do not. These are conversations that really need to begin long before there's any hint of illness, because illness can come up on us gradually, or it can be quite sudden. So, we sort of say it's always feels too early until it's too late. So we really do need to spend some time thinking about what's important to us.
Excellent. Thank you, Jackie. Excellent advice. So we do have a little introduction for all of you who may not, I think Jane Macdonald has called it another, secret gem on the Sunshine Coast, which is Hospice House. And we have this beautifully produced video to introduce you to Hospice House and Tess Huntley.
Hi, welcome to Hospice House. This is the space where we have our programming and where our staff team work. And come on in and we'll look at the newly renovated program space. It was recently renovated by a group of volunteers, donated labor, donated materials, and what it's allowed us to do is expand our program used space for things like our palliative day program, which takes place here. People meet informally and formally, and of course it also hosts our Kate Webb Library, which we've had for many years, but has recently been transformed by one of our volunteers into what you see now, which is a beautiful display of all the books and resources that are available to members of the community on various subjects. And we heard from members of the public that they really valued these resources, especially over the pandemic when they were really needing to have some tangible things in their hands. So this space is also used for meetings, and our day program offered here, and we offer things like art therapy, music therapy, meditation and mindfulness, facilitated by members of the community who have experience and expertise in those areas. We also have informal sitting area where sometimes our client services coordinator will meet with clients. If they need to meet privately, we have private spaces in other parts of the building. So this is an area of Hospice House used by our grief groups, among other things. But the grief groups meet here in this private space. It has a separate entrance to protect their confidentiality. It's soundproofed. It allows people to talk about things which are incredibly personal to them, very confidential, and often quite difficult for them to talk about. But they're sharing that experience with people who also know that journey. Our grief group facilitators are specially trained to be able to offer this facilitation support and have years of experience in helping people navigate this time in their life. When people think of hospice, they often think about the hospice beds that are located in Shorncliffe, and they don't necessarily know about the broad range of supports and services that are available. People associate our services much more with end of life, and we would like people to know that there are things that are available to them much earlier in that journey, both to the person and, as I said, to their caregiver. People often ask if there's a cost to our services, and all of the services and supports provided through hospice are absolutely free for community members. Sometimes the hardest thing to do when you're going through these really difficult times in your life is actually to reach out, especially to strangers. We have staff who are well trained and well versed in working with people where they are and matching them, when appropriate, with individuals or groups who will really understand what they're going through and provide a circle of support and encouragement and services that will help guide and navigate them through that time. Our volunteers receive over 30 hours of dedicated training, as well as regular in-services that are provided throughout the year. They are an incredibly committed group of people. We have over 60 volunteers and more coming to us all the time who want to give back to their community. The volunteers provide a huge range of support, everything from one-to-one listening and spending time with the person to providing advice and information on how to prepare your advanced care planning, how to make your wishes known to your family so that you aren't waiting till the last minute to when perhaps it might be too late to let your family and friends know what it is you want. And that can be done at any time for community members now who are not experiencing a palliative or end-of-life diagnosis. It's always important to know what your wishes are, to have them written down, and to be able to provide that information to your friends and family so they'll have it when it's needed most. We try to offer our support where people need it. So that may mean going to people in the community, offering support virtually when they can't attend in person, trying to adapt it to exactly what people need, where they need it. We want the community to know that hospice is here for them and that our services and supports are available, but you can just come in for a cup of tea in as informal a way as possible to just feel out what it is that might work for you at this time. Our program space here at Hospice House is open 5 days a week, and we have a telephone line that's monitored 7 days a week. We want to invite people to learn more about what hospice has to offer in terms of the supports and services that are available to people experiencing bereavement or end of life or a palliative diagnosis. And we want to spread the word that the services are there, that they're free, that they're accessible and tailored to meet people's needs wherever they are in community and in their journey.
Lovely. It's time now for our panel to answer the questions that have been compiled. I'd like to bring in the Sunshine Coast Sechelt Hospital Foundation Executive Director. You can tell I've got a cold. Jane Macdonald is standing by with your questions, and it's not too late to submit questions. Please use the chat feature, and Jane will see them as they come in. So, Jane, what do you have for our panel?
Thanks so much, Joanna, and thank you, wonderful panelists. It's an absolute pleasure to be here today from the Hospital Foundation here at Sechelt Hospital. Couple probably short and easy ones, and then some longer ones that might be worth hearing from a few of our members. But could someone please share a bit more about what kind of support is available for caregivers throughout the palliative journey, and how does a family member who might be caring for someone who is palliative access the home care or the palliative care team services?
Well, I'll start. Our home care team are definitely very much a support for caregivers as well as clients. Of course, the Hospice Society volunteers offer support both to clients and could be specific support for caregivers as well. There are various online support groups, either like through BC Cancer, or there's a really good one online with a blog feature, which is virtualhospice.ca. Those are off the top of my head. Maybe someone else can jump in.
I think
So go ahead, Carmen.
I think BC Caregivers Network is also a really good resource for caregivers, and they have support groups as well, which can be virtual, which is nice, especially given where we live. And I think what's really nice about when someone is referred to the home care nursing team, and again, if you're feeling like your family member needs a referral, you can call it, or you can let your family doctor know. Your family doctor can put in the referral. But it's really nice because once they're on board and they've done the assessment to figure out what your needs are, they're going to be checking in with you along the way and saying, hey, are things changing? Do you need more support from us? Do we need to back off? And they really can meet you and your loved one where you're at. Patrina, correct me if I'm wrong, but the home care nurses work from 8 a.m. to 4 p.m. And then there's always a nurse on until 8 at night. 8 at night to cover that little after hours period. And there's a phone number for after hours. So from 8 p.m. to 8 a.m., there's a number you can call to talk to a palliative care nurse who's actually on the North Shore to help you with any issues. And then there's also respite. So if there are beds available at hospice, there can be respite time there. I don't know if you want to speak a little bit more to that, Patrina.
Yeah, yes, hospice, the actual physical rooms could be used for respite, but also we would try hard to get respite hours. So having a caregiver come in, like a home support caregiver, come in to relieve a family caregiver for a block of time, 2 or 3 hours. We definitely try to do that.
If I could speak to that as well on behalf of hospice, hospice volunteers can provide companioning to people who are palliative and at the end of life. And this is a form of caregiver support as well, because it means that the caregiver can leave and take a breather themselves. So that relationship can extend not just to the individual who is palliative, but certainly their families. And to access a hospice caregiving support, all they have to do is call. You don't need to be referred through healthcare. You can just call the Hospice Society directly for that.
Okay, we have a question here that again might be technical, and Jackie or whomever could answer, please. When filling out one's green sleeve and or looking at advanced care planning, could you describe what is the difference between power of attorney and medical directive or medical proxy?
Oh, that's such a big question. A power of attorney is a financial planning document. It gives the designated attorney, the person you're assigning that power to act as you in financial matters, and usually in all financial matters, from disposal of property and assets to day-to-day bank management, tax submissions, and things like that. You're talking about medical proxies or advanced directives. There are legal documents that are very, very specific about specific treatments for specific medical situations. And that is possible. As I said, it's a big question, and it's not necessarily useful to try and figure out in advance exactly all of the scope of treatments and interventions that you may or may not want, because you don't know what the trajectory of your illness is going to be, how it's going to manifest. So the most important thing is really thinking about what's important and making sure your family knows what's important to you, and you have to trust them and the communication you've had with them to guide them in making the decisions that you would make.
Follow up on advanced care planning and or the Green Sleeve program. If I were a paramedic, where am I looking for it in your house?
So the green sleeve typically is going to go on or near your fridge. It's got magnets on it. You can stick it on the front of the fridge. You can stick it on the side of the fridge. If you don't want it to be visible, or you have a non-magnetic fridge, which some stainless steel fridges are, then you can put it in the cupboard above your fridge or in a drawer beside your fridge, but somewhere in that vicinity. And part of the kit is 2 green stickers. 1 green sticker goes on your front door, and this is a signal as the paramedics come through the door that this house has a green sleeve, and they will go and hunt for it. And then the second sticker, if you've tucked it away, would go in the location. So if it's in a cupboard above your fridge, the second sticker would go on the outside of that cupboard. But another part of communication is making sure your family, maybe your neighbor, your emergency contacts know where to find it as well, or have copies of all the documentations in it as well.
Okay, a question on, we've heard symptom management and pain management. And when receiving home care or palliative care at home, how are the drugs handled, and are they safe, and who administers them, and who knows what to give when? And could you say a little bit more about that, Patrina?
So medications are prescribed to the client. They're kept in the home. We, the nursing team, talk about safe storage, and certainly if there were young kids around, you'd want to make sure any of those medications are kept safely. All the time, someone can take medication by mouth. That is the usual way medication is prescribed. But sometimes, as symptoms change, we move to an injectable format. The nurses, we call them butterflies, but they are small little cannula that go under the skin, and they're taped in place. And then the nurses would come probably every day or every couple of days, and they would draw up dose-specific medication. Never ask family to draw up medication. It's all drawn up, labeled with a medication sheet that is written out specifically for that patient client. And then we do a lot of teaching with families. So how a family member would administer that medication is, it's kind of like it's a syringe without a needle. There's no needles involved for family. And you just screw it onto a little attachment, and medication is given that way. And we can actually give a lot of medications that way. There are other formats. There are medications that are delivered through a patch, a longer format transdermal patch. But we can manage a great deal of symptoms that way. We do in home care have a couple of very sophisticated computerized pumps, so that's another option. They can deliver medication round the clock, and the nurses again set those up, and then the family don't have to have anything really to do with administering medication.
Great. There have been a few questions about MAID, and Carmen, maybe you could lead this part of the conversation and again explain what is available in our community and how the public should contact, who they should contact for guidance and for any sort of paperwork or even counseling on how to even consider medical assistance in death.
Sure. So you can talk to your family doc about medical assistance in dying, even if it's just curiosity or if it's something you're really wanting to pursue and you're wanting to know what paperwork to get done. But that's a definite, I would say, the first go-to person. So even if a family doctor isn't someone who is going to perform MAID or maybe doesn't do assessments, most family physicians on the Sunshine Coast do. So we're very lucky to be in a community that is so open. But it is your right to have that conversation as a Canadian citizen and as a patient. And so your family doc could refer you to another doctor on the coast. They can refer you to me. That's no problem, to further your conversation and fill out any paperwork that you want. So the process says there's 3 pieces of paperwork that need to get done for anyone who is wanting to apply to the program. And the first step is with the patient. The patient has to fill out a request form and have a witness them signing it. It all has to be done on the same day with your witness. And then after that, you can seek 2 more assessments. One be done by your family doc, and then another one, your family doc can help you find another provider for the second. Other ways to get more information about MAID beyond your family doctor. I think both of the palliative care resource nurses at Home and Community Services, so Patrina here and her partner Joanne, are great resources. Vancouver Coastal Health, which is the health authority the Sunshine Coast is in, have a really great website. And you can contact them, their MAID coordinating service, through email or by phone. So those are great resources.
Terrific. Thanks so much. I think that's about it on the question side, but just wanted to assure the audience that a number of the documents that Carmen just referenced and a few of the supportive documents from our friends at Hospice will be posted on our website as well as their website. And you can always call Home Care, which is a phone number we publicized far and wide last week, but just wanted to convey to the community that you are well surrounded by very loving and skilled professionals who will take care of you in your home and your palliative journey. And just thanks to everyone for what it took to pull off these 2 Medtalks. Back to you, Joanna.
Thank you, Jane. Yes, I would very much like to thank all of our participants today, Jackie, Shari, Carmen, Patrina. I love not only the information that you convey, but the calmness and caring that you convey as you're doing that. So I think that's fantastic. It is time for you as the audience to do a little bit of work, though. We would like you to go to the Hospital Foundation website and fill out the survey. The survey tells us how we're doing. Are we bringing you topics that you're interested in? It allows you to suggest some topics that you might want us to tackle. Just to give you a bit of a sneak peek, our next Med Talk will be sometime this summer, maybe early fall, and it will be on the topic of women's health. Not too broad a topic, no, not at all, but we can handle it. So thank you to everyone who was involved in putting all of this together. Thank you very much for tuning in, and we will look forward to seeing you all really soon.